started, guys? Okay. So I'd like to introduce Dr. Sol Gregory, who's graciously come to speak to us around adult burns and the new CPG guidelines. We have about 18 sites on, and hopefully everybody can hear me. Just kind of wave or whatever, but I'm sure you guys can. Dr. Sol Gregory works at the UBC Division of Surgery, and he works out of VGH, St. Paul's, UBC, sometimes here, sometimes Children's. So he's an absolute full of knowledge of burns care and plastic surgery. So I will pass it over to you, and hopefully this will run just smoothly. And come September, guys, hopefully we're going to have some support to actually do this technology-wise, and we won't have some of the difficulties we've had over the last 10 years. Or I've had, maybe that's
Okay, so is this mic working?
Yeah. Yeah.
Right. So, as you said, I'm Sol Gregory. I'm one of the grade 3s in plastic surgery, division of surgery, or department of surgery, division of plastic surgery. And we're, mostly centered around PGH, but we go to a bunch of different sites. I've been asked to talk to you about new BC clinical practice guidelines that we've developed. And I guess I kind of want to know, it looks like we have some OR nurses, and I recognize a couple residents, and there's some docs here. So I'd like to try and make this useful for the people here, but also for the people in the periphery. So I'll try and sort of jump around to address kind of the interests of everybody in the crowd, but it would really help if it's a little bit more interactive, and if I say something that brings up a question, it's really helpful if you just address it right away, and I'm kind of a tangential thinker, as you'll see when I go through this, so fire when ready. I will repeat the questions so that the periphery can stay involved, and we'll go from there. So above and beyond that, my sort of goals for this are to sort of tell you a bit of a story about how we pushed this initiative forward, how we determined that it would be a good idea, what went into actually coming up with the guidelines, and then talk a little bit about sort of historically how we resuscitated burns and some recent shifts, or at least over the last 10 or 15 years, shifts in how we deal with major adult burns. There is a distinction to be made. This isn't a pediatric guideline, and can't be interpreted as such. So I don't know, they always tell me to say this. I don't have any disclosures. Burn care is not particularly sexy, nor is it an opportunity to make lots of money, but I don't have any disclosures. So historically speaking, like many things in life and medicine, the people that get credit for concepts pretty much are the best promoters of the concept, as opposed to the first people that sort of discover these things. But essentially, when you have a burn, you lose three things: your ability to control temperature, your ability to protect against infection, and your ability to protect against insensible losses. And it's this kind of loss of fluid and the systemic response to the burn and the loss of fluid through leaky capillaries that is sort of, our understanding of this has kind of forged the cornerstone of burn resuscitation, which is early aggressive intravenous fluid resuscitation. So back to our promoters, we had sort of this information around the turn of the last century, but it wasn't until kind of the 20s to 40s where it really got popularized. And when you go to any sort of burn resuscitation talk, they typically talk about historical fires that people were actually able to administer strategies based on these lab experiments. So the two that always come up are the Rialto theater fire in New Haven, Connecticut, and the Coconut Grove fire 20 years later in the 40s in Boston. And what we sort of realized is that a lot of people would survive the initial trauma of the burn, but would die later secondary to shock. And so early aggressive intravenous fluid resuscitation became kind of the cornerstone. And the mortality dropped off. And so, many burns that were thought to be unsurvivable were now survivable. And the consequences of this success is that it kind of propagated this philosophy that we can aggressively resuscitate people, and we're cognizant of the fact that we can prevent shock, but we gave no consideration to the harm we can do with over-resuscitation. So this just goes back to my point before. These are all the published burn resuscitation formulas from 1940s through the 1980s. And I draw your attention to a couple points. One is sort of the age-old argument as to what is the best resuscitation fluid. And right from the get-go, people were considering colloids and crystalloids and salt concentrations and these kind of things. And really, we don't have an answer to this question. Nobody really knows. There's some studies that suggest that the risk of colloids outweighs the benefits, and some vice versa. It's pretty muddied water. Nobody has like a really good idea. People are kind of moving towards crystalloid, or had moved towards crystalloid. Now there's a movement back to colloids, and people try and do more sort of physiologic crystalloids now with things like, it's the one they use now, lactated ringers is a traditional one, but there's also the, losing it now, but the anesthesiologists are using... Balanced salt solutions. Yeah, balanced salt solutions, anyway. So, and early on, even at the turn of the century, the first ones actually had a high level of alcohol in them. They had this kind of like nutrition slash crystalloid slash alcohol. So maybe they were like dealing with, alcohol dependence at the same time. Maybe that's what it was. Okay. So here's kind of one of the big problems is this concept of fluid creep, or the ability to cause over resuscitation. And this is sort of a concept that was coined approximately 15 years ago, and it's well documented that we have increased incidence of pulmonary edema, myocardial edema, burn depth progression from over resuscitation, and extremity, as well as sort of the most feared complication of over-resuscitation, abdominal compartment syndrome. So in VGH, we're kind of the major tertiary quaternary center for burn care in BC. We have a closed ICU unit, so we come in and we make dressing recommendations, but the ICU is in charge of stabilizing them in the acute phase. And so often we come by, and sort of the culture of the ICU is to round once as a team, when really for burn patients you need to be monitoring their resuscitation very carefully and titrating based on urine output to protect against these complications of over-resuscitation. So we come through, and just like I told you, we propagated this philosophy just to give them lots of fluid, because that's going to protect them from morbidity and mortality. And we routinely come by and there'll be urine outputs of 200, 300 cc's an hour, when the thought now is that you're probably better off with a max of 50 cc's per hour, regardless of your body weight. So this was one of the areas of that we identified as a potential place where we could improve the care of our burn patients. So, there's kind of the typical way we deal with things. We come to the ICU, we kind of stamp our feet, we curse out our colleagues, and we tell them how to do their jobs better. But this was not working, obviously, not a great strategy. So what I tried to do is, I had just sort of an off-the-cuff conversation with an anesthesiologist on my anesthesia rotation in second year. And we talked about sort of the best ways to monitor volume resuscitation in the burn patient. And really we talked about lots of options, but we still think in BC urine output, and pretty much across the board everybody agrees urine output is still the best thing. And the reason for that is we can look at very sophisticated ways of measuring volume resuscitation, but you know, our population in BC is about 4 million, and you know, half of that's kind of scattered over almost 1 million kilometers. And so that means that in the really important acute stage of the burn and the need for fluid resuscitation, usually it's less experienced rural docs that are dealing with this. So we need to give them some tools that are going to allow them to have some success with their burn resuscitation to get them down safely to us, so we can handle the surgery aspect. So we established a multidisciplinary team with emergency, trauma, critical care, anesthesia, plastic surgery, BC Helijet, and we also had consultants from nursing and support staff. And we looked back in our burn database, and we had a couple hypotheses. One was that we were noticing that when people came to us from the periphery, the burn extent estimation for which you base your initial fluid resuscitation volumes on was often wrong and often overestimated. And we were wondering if there was, you know, increased complications based on these overestimations. And so we did actually find that 82% of the burns that came to us from the periphery, that means non-BC Lower Mainland, so we didn't count Fraser Health, but anything outside of Fraser Health and up into the interior, 82% of people were being overestimated compared to what we thought when they got there, and that the average overestimation was 10% TBSA, so it was a significant amount. We also found that the odds ratio was 45 times greater that you develop abdominal compartment syndrome if you had your burns overestimated in the periphery. So these were kind of two of the areas where we focused our efforts. So I might talk about these things and then we'll have to go on. So this is kind of the focus that I'll talk about, but we were really trying to streamline everything from, you know, the patient getting to the rural doc, to the transport down, to the emergency room, to like getting ushered up to the ICU, stabilizing them, preparing them for surgery. We took a look at all of these aspects. So after we had determined that there actually was a need from our database, I did a literature review, and essentially we sat down as a group, reviewed all the literature, and we came up with the protocols based on consensus. So one of the things that I alluded to before is the difficulty of estimating burn extent. So essentially, in order to estimate a burn, you take the second degree and the third degree burns, which are essentially partial thickness or into the dermis, or full thickness through the dermis, and you estimate what percentage of the body surface area these make up. And the most widely promoted burn resuscitation formula is the Parkland formula, which is 4 cc's per kilo per total body surface area. So if you're overestimating, you're going to start with a lot higher fluid resuscitation. And then in transport, often they're not monitoring hour fluid resuscitation. They're just at the initial goal rate. So you just need to be really careful with that. So one of the problems was this estimation. Most people use the rule of nines, and typical kind of mistake would be, you know, if they have a leg involved or anterior thigh, they would call that 9 because the leg is 9. I mean, it's pretty basic stuff, but it can have some pretty deleterious effects. So we have rule of nines. Also, another commonly used strategy is the palm. The palm of the patient's hand is approximately 1% total body surface area, at least in white people. Asian people, it's a little bit less, 0.8. Anyway, so this is not new, but it's hopefully new to some of our rural docs. This is the Lund-Browder chart, and what it allows us to do is just specify part by part a little bit more specifically so that they can get a little bit more accurate. It should, with a little bit of coaching, it should be pretty straightforward. It's pretty intimidating when you get a big burn-in, but essentially red skin doesn't count. If there's blisters or, leathery, full thickness burns, those count in your estimation. So this is something that, along with the other protocols, would get faxed or emailed out to the rural docs when they initiate the BC bedline transfer down to BGH.
Oh, okay.
Is there a question from sitting elsewhere?
Okay. Thank you.
Can you please make sure your phones are on mute at the sites? Thanks.
Wow. We can hear someone from some site. I'm happy to fill the question, but if you're not asking questions, you can turn off your mic, please. I think we're okay. Anyway, so this is just a little bit of a close-up. You can see, adult head is 7%, anterior, posterior, and then you just add it up. I mean, it's pretty straightforward, but we're hoping that this will give a basic tool. Moving forward, there are some, we'd like to use sort of video conferencing so we can actually go through it with the rural docs. And we do have telemed set up, but it's not really super functional, and there's some confidentiality issues. So I think that is something that's going to come up in the future, but we're not really there yet. So hopefully this will bridge the gap. And this is just initial kind of assessment tool for the rural docs. We know that the first sort of 12 to 24 hours is crucial in terms of accurate resuscitation and protecting the patient against over-resuscitation. So this just gives the docs a sort of stepping off point. So you identify this burn. These forms are faxed out, and then there's initial things, depending on your capabilities in the periphery, different monitoring, and then you have some basic goals. And essentially, the big change is that we're just looking for a urine output goal of 30 to 50 cc's, regardless of body weight, and that you're titrating based on this. So if you think your initial goal is an hour, and their urine output is 150 cc's, you're gonna taper that back by 20% each hour. This is just a little bit closer up. So you're assessing the TBSA, you're getting IV access, you're using lactated ringers, which is what we use. Again, this is kind of arbitrary, and these were done by consensus. We're just trying to make it as easy and straightforward sort of initial approach for people. If you have CBC or line capabilities, that's a bonus. If not, you're going to stick with your urine output. Any questions about this? So once they're in the tertiary care, or if they're stranded up north, there's weather delays or whatever, this gives a little bit more of an in-depth look at how to initially treat the burn. So we have up at the top, that top horizontal, we essentially have initial monitoring, we have general management checklist, and then we have initial goals, and then underneath we look at strategies to prevent over-resuscitation in a not very straightforward patient. Now, with any clinical practice guidelines, you can't deal with every patient, and critical care is complex, and you need to deal with people on an individual basis. But kind of what I've gathered from reading and talking to the experts in the field is essentially the most important thing is you have ongoing reassessment, and to realize that in a not very severely injured patient, fluid resuscitation works very well. But if the person is really sick and they're getting liter after liter as kind of a, you should be asking yourself, if they're getting a liter every hour for three hours and you're still like fighting the urine output, you need to kind of change your strategy, or you will head towards iatrogenic injury. And if that means putting them on Prisma, or trying other fluids, or trying colloids, or allowing a little bit of permissive hypotension if they don't have a head injury, these are some things that you should think about early rather than late, because really the abdominal compartment syndrome is an inappropriate response to failed resuscitation. And so that's what we're ultimately trying to reduce here. So this is just a little bit closer look. I'll just sort of go through this. So arterial blood pressure, CBC, SpO2, lactates, ABGs, bladder pressures to monitor against abdominal compartment syndrome. And then if you have high abdominal pressures, then increasing the frequency of those checks. And then general management. These are things that are generally for any kind of ICU patient, head of bed greater than 30, gastric prophylaxis until they're feeding, and DVTs, dressings for plastic surgery, and so on and so forth. And then the initial goals are just benchmarks. And if you're not easily reaching these things, then that's a time where the critical care physician can either discuss things with the rural doc or manage the patient if they're down in our center. I guess the one thing to note is that with the systemic response to the burn, the normal temperature is higher than a normal patient. So a temperature of 38 is completely normal. If you're getting 37 or below, that's a hypothermic patient, and that's a problem. Okay, so down here, now there's no real right or wrong. We based our strategies for reducing the amount of fluids given based on protocols that have shown successful outcomes in the literature, but there's not a lot of this is kind of level 3 evidence. So our strategies are, one, initiating some colloid resuscitation, or allowing some permissive hypotension in patients without brain injuries. I had another thought here, but it's gone. Okay, I'll come back to it. Okay, so one of the things that we know from the literature is that if you receive more than 6 cc's per kilo per TVSA, or greater than 200 cc's per kilo over the first 24 hours, you're at a significant increased risk for abdominal compartment syndrome, which is the most feared complication of over-resuscitation. So one of the strategies out there employed by the US military is a 12-hour check. So essentially what you do is you record the fluid given hour by hour, and when you get to 12 hours, you anticipate how much fluid the patient is going to get over the first 24 hours. And if it's above those cutoffs, above 6 cc's per kilo per total body surface area, or greater than 200 cc's per kilogram, then you increase your monitoring for peripheral and abdominal compartment syndrome with bladder pressures and peripheral pulse checks. So this is just the flow chart. So you've done your calculation, and it just allows you to go through it in a simple way. Is this a high-risk patient or a low-risk patient and contact the physician or consider increased monitoring at this time. Are there any questions about this?
Just one question, another question for this one. Is this going to influence how ATLS is development with respect to burns? Have you had any discussion with that group?
Yeah, so the question has to do with ATLS and what the discussion is with them. So currently the ATLS follows the Parkland formula that we've been discussing, the 4 cc's per kilo per TVSA. And at least locally, we've discussed kind of the findings in our database and told them about the risks of over-resuscitation. So there is a shift, and obviously that's a very good way to get the word out. I'll talk about some of the strategies we're using to try and promote our ideas, but they'll probably be kind of late comers. But the ABLS, the acute burn protocols in the States have recently gone to an initial goal of 2 cc's per kilo per TVSA. And the reason is they're finding the same thing, that they're having over-resuscitation. And I don't think that's based on what is the most efficacious initial goals. I think that's based on just a reaction to the amount of over-resuscitation they're seeing. And they're actually considering doing away with any like formulas and just saying, if you're over 14 years of age, your initial rate is 500 cc's, and then you're going to titrate from there to sort of get rid of any of the confusion. We have another question.
Is part of the 12-hour assessment then a formal reassessment of the degree of body surface area burn? Because it may be more obvious then, and as you say, it can mislead you in your treatment.
Right, so the question has to do with accuracy of burn extent estimation, and the point's well taken that burns evolve over the first 42 to 72 hours. You can have burn progression, but typically you don't have burn regression through that time. And because the problem we're trying to combat is over-resuscitation, usually that's not a problem. The burns may get worse over that time period, but that wouldn't cause you to overestimate them. That would cause you to underestimate them. And really at that stage, you're kind of out of the, the cow's out of the barn at that point. Like if you haven't been vigilant in the first 24 hours, then they're either doing great or you kind of missed the boat on someone that's a little bit more complicated. But that's well taken. It can become more obvious, and the burns often progress over that first 3-day period. Any questions in the periphery? Most of the people at this site, I don't think, deal with too many burns, so this is kind of a rounds of interest, but you might actually see these people up north, and I'm happy to field questions at any point. Okay, so just going over the goals here: accurate estimation, ongoing vigilant resuscitation and adaptation based on urine output, 30 to 50 cc's per hour regardless of the mass, and just checking and rechecking essentially is basically the keys to this. So I want to talk a little bit, like for someone in their third year, I'm often kind of intimidated by the bureaucracy of the hospital. Like even as early as recent as 30 years ago, there was one hospital administration person at UGH, and now there's like floors of them. And so I really thought that we'd meet a lot more resistance as we were trying to establish these clinical practice guidelines and get them into use. But we kind of took I don't know, I'm a parent. Are people parents here? Parents? So I've got kids, and it's kind of like, if the kid just does it, maybe you don't ask any questions as a parent, but if they say, hey, Dad, can I do such and such? Then you think, oh, well, I'm a parent. I need to make a decision, is this good for my kid or is this not good for my kid? So the kind of approach was to get consensus across a number of disciplines and present it like, these are the experts in the field. They've reviewed the literature. We think we can improve outcomes by implementing these strategies. And it actually went quite smoothly. And in fact, the administration kind of grabbed it and ran with it and actually promoted it even before it was really in a workable form. And all of a sudden we had BC guidelines and, other hospitals were bent out of shape that we didn't consider, them in the protocols. But it wasn't really like that. We were looking at it was basically a quality assurance for BGH and the people that were coming to BGH, and it's kind of expanded. So I expect that it will evolve over the next year or so, and then the plan is in 5 years to go to the burn database and look to see if it made any difference. So things we're doing, we presented a number of different trauma emergency plastic surgery meetings. We've got a BCMJ article in the works that sort of outlines the protocols as well. And we're looking at sort of internet-based modalities to promote this. So just want to acknowledge my team at BGH. And this is a poster I put together for a burn meeting that won an award. And I guess I just want to open it up to you guys to ask any questions you might have. Yeah, please.
I guess the smaller sites out there, if they get a burn that comes in, and they should be basically talking to BC Bedline right away so they can connect up to you guys so that they can get these protocols, the practice guidelines?
Yeah, ideally. We have a plastic surgeon on call all the time, and they're pretty accessible. We have a burn director who's available for any major burns and an on-call plastic surgeon. So it's good to connect with them and just talk through the burn. And if you activate BC Bedline, you'll get these forms, and that should hopefully help you out a little bit. And yeah, it should be ongoing communication with the sites. In terms of things we notice, other than the difficulties of accurately estimating burn extent and just generally starting with a little bit too much fluid, it hasn't been a problem in the recent days. But one thing, we used to get burn patients dressed in damp gauze, and that can be a problem with hypothermia. Again, the big problems you have are fluid loss, temperature control, and prevention of infection. So if you've got a big burn you're going to be sent down, probably just dry gauze is the best thing to put them in, because we're going to be taking everything down to assess the burns when they get to BGH anyway. Yeah, please.
So I think this is an excellent topic for a couple of reasons. Number one, you're talking about a system change and it's provincial-wide. So kudos to you guys for doing that, and it's a great idea. And you've done a fantastic job. The other thing is I think it's reflecting the change in trauma resuscitation. So trauma resuscitation is starting to use permissive hypotension. We are trying not to turn our patients into Michelin men and women, and it does affect longer term. When I do a trauma laparotomy, I can't close them for weeks because they've gotten 12 liters of fluid in the first 12 to 24 hours. So I think this is a whole shift. And with respect to ETLS, there is a new edition coming out. The 9th edition is coming out this fall. They try not to be too specific about some things because there's been so much multiple organ failure associated with under-resuscitation that the pendulum can't swing all the way to no fluid resuscitation. So ATLS sort of tries to find the way in the middle there. And but they are aware of damage control resuscitation. They are aware of appropriate burn resuscitation. The folks who lead ATLS, it's Dr. Karen Brazel, who's also a trauma surgeon in the US. But you can only do so much with such a large course, especially one that's international. But I think overall this is an excellent way of demonstrating, and something that used to be the bastion of a lot of fluid resuscitation, that we're now backing away from that, and hopefully the trauma studies that are coming out will reflect that in blunt trauma as well as in burns, as well as in penetrating trauma. So great work.
Thank you. So I'll just summarize here. It was more of a comment than a question. The comments were that generally we're recognizing over-resuscitation across all trauma patients, whether it be blunt trauma or burns, and that this can have negative effects. The example given was closure of a trauma laparotomy being difficult with over-resuscitation. So there is a shift back, but again, there's some hesitation because we don't want to shift too far back and compromise organ perfusion. Yeah, please.
I have a question as well.
Oh. Yeah, please ask. I'll take the peripheral question.
We're wondering if it's possible to get copies of the clinical practice guidelines you've shown today. If you could give us a contact number or.
Yeah, sure. I assume you're on the email list, and I'll just give you my email. But there's a Facebook page, and they can be accessed on the Vancouver Coastal Health anesthesia section of the website. But I'm happy to give you the link, and I'll forward my contact information to the trauma people here, and they'll share it with everybody.
Thank you.
I have a couple questions. Obviously, there's been fairly high-profile province this year, but in general, you mentioned that you see more from the north or in the rural areas than
it's about urban areas. In terms of where we see our burns coming from, it's almost identical to our population, but half of them are from Lower Mainland, and that's similar to half the population. Half of them come from the periphery.
And most of ours have to do with personal laboratories, and so I'm wondering how much other trauma is associated with the burns that you see in the quaternary care setting, in terms of other significant blunt trauma.
So the question was about the recent highly publicized burns. I guess you're referring to, we had a big plane crash and a couple pilots that passed away. We had the Burns Lake mill explosion, and then most recently we had the PG explosion. The question is how much trauma are we seeing concomitantly with our burns? And we do see some, but because I think we see less because it increases the mortality so dramatically. If you have a major burn and concomitant injuries, we probably don't see that much. We usually kind of see one or the other. It's sort of in our realm. We usually see someone with bad facial fractures, but their head is fairly well preserved. And the neurosurgeons, conversely, will see people with not too many facial fractures and brain injury. They like to tell us that the face is just the airbag for your brain. But I think it's more I think it's more like a selection bias. I think people that are badly injured and have major burns we don't see them. Yeah.
So with these burn protocols, what percentage of burn patients come in assessed as being adequately or perfectly volume resuscitated, what percent are over resuscitated, what percent are under?
Right, so from the periphery, 82% are overestimated by an average of 10% with a 45 times odds ratio of acquiring abdominal compartment syndrome compared to someone who's initially resuscitated in the lower mainland. And we're not doing a great job of it either. We're over-resuscitating still.
One more question. What do you expect to see in the quaternary burn center? I guess a lot of it, in the adult population, is it more than 20%? Because it's changed over time in terms of outpatient burn care. I guess a lot of it depends on renal function and age. to include guidelines about who should be transferred now?
The question is who is
Who
being
you would like to
referred?
see, yeah.
Yeah, so essentially, we want to see more and more people. As the indications for referral to a quaternary center, the center of excellence, evolve, they get more and more widespread. So basically, it's really any full thickness burn, and I forget exactly the numbers, but it's as low as like 5 or 10% second degree burn, anything over a joint, anything with concomitant trauma, anything that's a pediatric, anything that's in an elderly frail person or someone who has multiple comorbidities. But so really, like, we're not upset seeing people. We'd rather see someone that doesn't need to be down there than there's not that many burns anymore. We've gone from, can't remember exactly the numbers, admitting maybe 15 years ago admitting 200 burns a year, to now we maybe admit, I don't know, 30 or 40 or 50, kind of in that range. And, granted, a lot of that is that we manage a lot of people as outpatients that we couldn't previously manage just because of our dressing care technology. But, a lot of it is just industry standard and work safety and the decrease in sort of industrial, you alluded to, like some of the home chemistry labs that we see maybe aren't being covered by WCB or work safety. Anything else from the periphery? Okay, well, I guess I'm a little bit under time, but I really appreciate your attention and have a lovely day.